Hi, hello guys, this is Shahul. Welcome back to another module. Today we'll be studying about respiratory disorders of newborn. I'm actually, right now I'm going with some series of pediatric topics. If the pediatric topic is completed, probably I'll be going the next subjects. So, coming to the most common respiratory disorder of newborn is tachypnea of newborn, which is not so serious, okay. It is in fact the most common respiratory disorders in which is seen in newborns, and we have the mechanism why that respiratory disorder of tachypnea of newborn is happening. See, normally we know that in intrauterine life, the lung is hypoplastic. It is just filled with fluids. It is just a bag of fluids. Ventilation is not taking place. Ventilation is actually taking place through the umbilical vessels. Fine. So the lungs are just hypoplastic in intrauterine life. What happens is when the baby is born, that is the first time the baby starts to breathe. Okay, that is when air enters the lung. Till then air is not there, will not be present in the lungs. Okay, so we have fluid here. Normally during vaginal delivery, we have a genital tract of the mother and the baby is coming like this. Okay, I'm very bad at drawing diagrams. Just assume this is a baby which is coming out. Okay, smiling. Fine. When the baby is coming out, you can see that the chest is being completely squeezed before the baby comes out. The chest is being squeezed by the mother's genital tract, and during that squeezing, this fluid will come out. Okay. What will happen in LSCS? In LSCS, this thing will not happen. We will be making a wide incision, we will take the baby out, we don't squeeze things, because of which the fluid is still retained in the lungs, and this fluid is not allowing the normal ventilation, and because of which the baby will have tachypnea. But the thing is, it is not so serious once again, because it will be settling within 72 hours. These fluids will be absorbed by the lymphatics within 72 hours and the baby will come back to normal. We don't have to do anything, no intervention is necessary. And how will you find it as a tachypnea? How do you find it as tachypnea? See, for newborns, we call it as tachypnea when the respiratory rate is more than 60 per minute. This is an important Neet question. Fine. When the respiratory rate is more than 60. For more than 2 months, no? For more than 2 months, the respiratory rate has to be more than 50 to call the baby to be having tachypnea. Fine. These are all a different topic. What we can say is the baby will having just tachypnea without any respiratory distress and all. The baby will just have tachypnea and will settle within 72 hours. When you take X-ray at that point of time, you can expect to have a prominent bronchoalveolar markings. You know how a prominent bronchoalveolar markings will be. Now coming to very, very important topic, respiratory distress syndrome. Every year one question from pediatrics is from respiratory distress syndrome. They frequently test this topic, so I just want to make it come or kind of elaborate. Okay, so first you need to know that respiratory distress syndrome is common in babies. Why it is common? Common in preterm babies. Why it is common in preterm babies? Now, you know, there is something called as surfactants, and which is necessary to decrease the surface tension. Everyone knows this. Okay. When I teach you about the biochemistry of surfactants, I will elaborate things. Now we just go with the clinical feature and see the clinical features and management, then we will be studying with biochemistry. So how will a baby be presenting to you with respiratory distress syndrome? The baby will have chest retractions. You can see that the ribs are completely indrawing when the baby is inspiring. You can see nasal flaring. You can see grunting. What is grunting? If you know, no problem. If you don't know, let me explain it to you. Grunting is a process by which the baby tries, it is a kind of adaptive process by which the baby creates a sound like this. See, let me put, don't make fun of it, just I'm making the sound, which means the baby is closing the glottis and he is trying to expire forcefully, because of which the sound like this, which I made, no, this kind of sound will be coming continuously. That is what grunting. When the baby is grunting, it is a sign of respiratory distress syndrome. Okay, the baby will have tachypnea because of hypoxia. You can also expect cyanosis in the baby. See, this is a normal lung where you can see bilateral opacity, sorry, not opacities, you can see translucency, the lung is translucent, but see here, it is completely white out. Is that not looking like acute respiratory distress syndrome, which is usually common in adults? It is one kind of childhood acute, we can also call it as childhood ARDS, because the lungs is completely white out, the lung is completely filled with fluids, because of which we have homogeneous opacities here. This is the respiratory distress syndrome X-ray. This can be asked in examination. In a newborn baby, if an X-ray is given with completely white out lung, 99% the examiner is channeling you towards respiratory distress syndrome only. Fine. Coming to very important scoring, Silverman scoring. Bro, this score was tested and asked 2 years before in AIIMS examination. Yesterday itself I told you how to study a score. First, know the significance of the score. Why this score? What is the use of this score? See, this score we used to put in preterm babies. We used to calculate the score in preterm babies to assess the severity of respiratory distress syndrome. Number 2, coming to the components. So, what are the components of Silverman scoring? Components. Why my handwriting is so bad? So, first we have 3 components. 1, 2 and 3. Okay. So the first component is chest retractions. Number 2, it is nasal flaring, and then 3, it is grunting. I told you, I made that peculiar sound, that is grunting. Just divide the chest retractions into 3 things, that's it. Upper chest retractions, middle chest retractions, and lower chest retraction. So it has 5 components. Component number 1, 2, 3, 4 and 5. This is what Silverman score is about. We calculate the Silverman scoring for a total of 10. If the baby is having a Silverman score of more than or equal to 7, then it indicates it is a very serious condition. We will have to manage it immediately. I just want to make a comparison of Apgar score right here, because we have lot of similarities between Silverman score and Apgar scoring. See, coming to Apgar scoring. What is Apgar scoring? What is the significance of Apgar scoring? It indicates the overall health of the baby. Overall health of the baby. Here we calculate it for term babies, for every babies in fact. For every babies, we will have to calculate the Apgar scoring. Here we calculate it for preterm babies, here we calculate it for term babies, and here also we have 5 components. Just remember the mnemonic. If, bro, it is you who has to keep the mnemonic. Okay. See, be creative in creating mnemonics, because without mnemonics you won't be able to crack any competitive examination as far as medical field is concerned. It is very difficult to study without mnemonics. Lot of things, lot of facts, lot of stuff you will have to remember, and it is, I personally believe it is possible only with mnemonics. See, some will be interested in food, some will be interested in places, some will be interested in any of the different fields. You can keep mnemonics as of your own. Don't try to copy mnemonics from others, because when you keep mnemonics, it will stay there in your brain for a longer time. But still, for those people, I'm just making it easier. Just remember the mnemonic march. Just convert it into MRRCH, that's it. MERCH to just write the word MRRCH. So M for muscle tone, R for reflex, another R for respiratory effort. Bro, it is not respiratory rate, it is respiratory effort. 4 is C for cyanosis, and H for heart rate. Fine, we have 5 components, 1, 2, 3, 4 and 5. Here also we calculate for, we give the score of 0, 1 and 2 based on the severity. Here also we give the score of 0, 1 and 2. Similar to Silverman scoring, the score here is also out of 10, but the baby has to have a score of 7 to call it as normal. See here, more than 7 or equal to 7 is serious. Here more than or equal to 7 is normal, as far as Apgar scoring is concerned. One factual, very important information, Apgar scoring is not to assess the severity or not to assess the necessary for intubation or any management kind of thing. It is just to indicate the overall health status of the baby. Fine, that's it. So just compare this scoring, it will be easier for you. This is for preterm babies, especially for respiratory distress syndrome. This is for normal babies. Next, coming to the treatment of respiratory distress syndrome. See, nowadays when the questions are asked, what is the next step of management, what is the best step of management? Usually student gets confused between next step and best step. Next step, now what has to be done next? It might not be the best step, but that has to be done immediately. For example, sometimes very silly kind of questions are asked. See, a baby, it is not actually silly, it is logical, but if you don't study the question properly, there are increased chances that you might commit mistake on those things. If, for example, or a question, next step of management has to connect fluids, that will be one option, but the best step we would have studied. So, for example, let me tell you, in the intestinal obstruction, the case of intestinal obstruction is given as a clinical scenario, and they are asking what is the next step of management. First option will be laparotomy. First option, every time we need question, first option will be very attractive. Okay, it will be like a beautiful girl. The moment we saw, we go for it. Okay, don't go for it, wait, see all the 4 options and then select the best option. See, if at all next step of management for respiratory distress syndrome is concerned, first give oxygen, bro. Don't go with artificial surfactant and all. That is the best management. Okay, last management. First go with oxygen. Most of the 90% of the babies will settle with just oxygen supplication. Oxygen supply itself. If the baby is not settling with oxygen, you go with CPAP. You would have seen how we give CPAP in adults. We will keep a mask, tie it over the face tightly, and we will be giving CPAP. But for pediatrics, no, the CPAP will not be like this. CPAP will just be like this only. Just through the help, with the help of nasal prong itself, we can maintain a positive airway pressure. So if it is not settling with oxygen, you can go with CPAP. If it doesn't even settle with CPAP, then we will have to give artificial surfactant. This is a very important question, lucinactin, artificial surfactant. You know how we will be giving artificial surfactant? The route is intratracheal. Intratracheal. Okay. And we have a specific named step for it. We call it as insure. What is insure na? We will have to intubate, give surfactant and extubate. Intubate, surfactant and then extubate the baby. So the route of artificial surfactant is intratracheal. This is also one of the neat question, very important. Fine. Okay. So this is how we manage the respiratory distress syndrome. See, you know this proverb, prevention is better than cure. Why is it being said so? You know that respiratory distress syndrome is common in preterm babies, especially babies who are born before 34 weeks of gestation. So as far as if for example, if any OG condition is there in which you will have to deliver the baby before 34 weeks, or the baby in the mother had a previous history of preterm, if you are suspecting that the baby will be coming to this world before 34 weeks itself, now you can give steroids. If you give antenatal steroid, this helps in maturation of the lungs. It hastens the maturation of lungs. Okay, and very important question, this is one of the very important neat question. Antenatal steroid not only prevents respiratory distress syndrome, it also prevents necrotizing enterocolitis, it also prevents intraventricular hemorrhage. So it is a very, very important drug as far as preterm babies are concerned. When you are suspecting preterm, go with steroids. But after 34 weeks, it is useless to give steroids. Okay, if you are suspecting delivery before 34 weeks, go with steroids. You know what is the dose of steroids? I think most of the people will know the dose of steroids. It is okay, let me write here. See, we use two protocols. One is Indian protocol. India follows one protocol. The remaining whole world follows the other protocol. Okay, Indian protocol is dexamethasone, dexa, 6 mg, 4 doses, 12 hours apart. Very, very important dosage, you will have to remember. World follows betamethasone, 12 mg, 2 doses, 24 hours apart. Okay, so this is how we give in dexa. Route is IM. Most of the CRRIs, BCRRIs would definitely have given dexa to most of the many mothers. You know that. Now coming to the surfactant biochemistry. Bro, actually my way of teaching is to combine one topic and like take one topic and get you all the relevant points from different subject about that topic. This is my goal. For example, if I take respiratory distress syndrome, I will teach biochemistry part of respiratory distress syndrome, pediatrics part of respiratory distress syndrome, even pathological part of respiratory distress syndrome. Because nowadays these kind of integrated questions are very, very common. It is occurring. Okay, coming to biochemistry, lecithin. What is surfactant? It is lecithin. Lecithin is also known as the every point which I am telling right now is very, very important. Very, very important. Every alternate year, one question is from surfactants. It is also known as dipalmitoyl phosphatidylcholine. DPPC. Lecithin is also known as dipalmitoyl phosphatidylcholine, which is a mature surfactant. Okay, which is a mature surfactant. Fine. What is sphingomyelin? It is an immature surfactant. Okay. See, surfactant production, very important. It's kind of volatile also. If you want to take notes, you can also take notes. See, surfactant production starts after 20 weeks. At 20 weeks of the gestation age itself, baby's lung will start producing surfactant, and surfactant appears in the amniotic fluid after 28 weeks. If you want to see the surfactant in amniotic fluid, you will have to do amniocentesis only after 28 weeks. Before 28, you won't be seeing, but the surfactant production starts at 20 weeks itself. So examiner can confuse you with these words. Then mature surfactants appears only after 37 weeks. Sorry, 34. Mature surfactant na dipalmitoyl phosphatidylcholine. So what you will see between 28 to 34 weeks, you will see sphingomyelin, which is an immature surfactant. After 28 weeks, you will just see sphingomyelin. So there are few tests in which we can assess the maturity, whether the lung has attained maturity or not. One is LS ratio. LS ratio is nothing but lecithin by sphingomyelin ratio. So normal ratio is 2:1 or more than 2. Just remember more than 2. If the lecithin is twice the concentration of sphingomyelin, then it is a very good sign that the lung has matured. You know that this is logical only, no? See, lecithin is there, which is a mature surfactant. Sphingomyelin is there, which is an immature surfactant. For that, we need to have more lecithin. If the lung is mature, obviously more of lecithin will be there, less of sphingomyelin will be there. So the ratio will automatically become more than 2. If it is more than 2, then it is a very positive prognostic sign that the lung has matured. Okay, fine. And next we have something called as shake test and nitro blue test. Even this is also asked in the NEET question. See, shake test is just we take the amniotic fluid and we add ethanol. Amniotic fluid plus ethanol. We add some drop of ethanol in a test tube and we'll just shake. If you see bubbles, then it is a sign that the lung has matured. If you don't see bubbles, it is a sign that the lung has not matured. This is what shake test is all about. There is one named test called nitro blue test. Just remember the name. Nitro blue test, you will have to see more than 50% of, there are two cells, one is blue cells and the other being orange cells. You will have to have more than 50% of orange cells to call the lung to be matured. Okay, if the cells is more, the orange cell count is more than 50%, then it is a prognostic sign that the lung is mature. Fine. Coming to surfactant proteins A, B, C and D, just remember militaries will be at the border. Okay, polices will be at the borders. So A and D is in, so the police force of our body is immunity. So A and D surfactant protein is involved in immunity. These are surfactant proteins. Okay, any defect in these protein will lead on to another condition. I will tell you. Okay, this is what you need to know about the surfactants. I told you in the beginning itself that I will be explaining about the process of grunting. Why grunting is happening? Let me explain it to you. See, this is alveoli, and surfactant will be produced by type 2 pneumocytes. This everyone will know. Surfactants will be present like this, and it prevents the collapse of the lung. So this collapse of prevent pandradhukku what we need, that is why we need surfactant. Okay, so if the surfactant is not produced automatically, the alveoli will collapse. Alveoli will collapse, which means if the alveoli collapses, we won't be the baby will go in for hypoxia. Okay, to compensate with what the baby will do, no, especially this collapse of the alveoli will happen only during expiration. Bro, if you want to know the practically experiment about surfactant, no, take one carry bag, bro. Just take one carry bag, or even take one balloon, inflate it. If you leave, no, automatically the balloon will collapse. Or add some 2 to 3 drops of water. Do this, take one balloon if you want to do experiment, or just imagine at least. I am taking my one balloon, I am just adding 2 to 3 drops of water, I am inflating it. When I leave it, no, the water will make the two sides of the balloon to collapse. The water will completely collapse, the balloon will completely collapse. Usually water is present in the lungs, that is why alveoli is collapsing. To prevent that, just add 2 to 3 drops of oil and then see whether it is collapsing or not. It won't collapse because oil will repel each other. That is what the role of surfactant in lungs. So during expiration, for example, like assuming a balloon, when during expiration the alveoli will collapse. To prevent this collapse only we had alveoli, but in respiratory distress syndrome the alveoli is not be able to be prevented from the collapse, so it collapses. Okay. To prevent this collapse, what the baby will do now, the baby wants to maintain a persistent or permanent or continuous positive airway. When there is continuous air, the lungs will not collapse. That is why the baby is doing this sound. When it doesn't know, what it is happening is, when the baby is expiring, but still the baby is maintaining a positive pressure by closing the glottis. When you close the glottis and you expire, the air will be trapped inside the lung. You will maintain a continuous positive airway pressure. This is natural CPAP. What the baby is doing is, grunting is a way of natural CPAP by which the baby is trying to maintain the positive pressure. We call it as peak end expiratory pressure. That is why the baby is doing that grunting. When it does the grunting, the alveoli will not collapse. When the alveoli does not collapse, you won't have hypoxia. So automatically the baby adapts. So what does grunting mean? The lung is collapsing, because of which the baby is trying to prevent that collapse. So you will have to intervene. Grunting is a poor prognostic sign. You will have to immediately manage the baby. You will have to manage the respiratory distress syndrome. This is the mechanism of surfactant. This is the function of surfactant. Coming to the next topic, we have pulmonary alveolar. Just remember 2-3 points about pulmonary alveolar proteinosis. See, I told you we have 4 surfactant protein, SP, A, B, C, D surfactant protein, and I told you A and D is involved in immunity, B and C is involved in normal surfactant function. When any defect, structural defect is there in B and C, no, what will happen? Surfactants will be there. Before that, let me tell you one point. Normally, continuously type 2 cells will go on producing surfactants. This is new surfactants. This is old surfactants. After 2-3 days, no, the surfactant will become old, and this surfactant has to be engulfed by the macrophages. The macrophage has to engulf this surfactant. When this function is not happening, the old surfactant will go on accumulating, and that will form a layer. That is what is known as pulmonary alveolar proteinosis. If it happens in children, it is called as childhood pulmonary alveolar proteinosis. If it happens in adult, we generally call it as pulmonary alveolar proteinosis. That is a medicine topic. In childhood, it is because of defective protein. In adults, it is because of antibodies against these macrophages. So antibodies will be died. Antibodies will not be able to engulf this old surfactant. So surfactant will accumulate. That is what is pulmonary alveolar proteinosis. You will have GGOs. You will have ground glass opacities in pulmonary alveolar proteinosis. Just remember these 2 points, that's enough. Coming to once again, another very important topic, congenital diaphragmatic hernia. See, we have 2 hernias. As far as CDH is concerned, we have Morgagni hernia, hernia of Morgagni, and Bochdalek hernia. See, let me draw you the transverse section of diaphragm. This is diaphragm. You know that on the this is anterior, this is posterior. On the anterior aspect, you have central tendon, and posterior aspect, you have this crura. This is anatomy. And you know what are the, we have 3 openings here, 1, 2 and 3 and all the stuff, that is anatomy. What I want to know, make you know is, see, when there is a defect here, when there is a defect here in the central tenon on the anterior aspect, it is Morgagni hernia. When you have defect on the left side, especially on the posterior aspect, it is called as Bochdelic hernia. So hernia of Morgagni is on the anterior medial, anteromedial part. Hernia of Bochdelic is on the posterolateral part, especially on the left side. This is repeatedly asked Neet question. Fine. So just imagine what will be there on the anterior part of the abdomen. You will have transverse colon, right? You will have to have transverse colon. So most of the time, 99% of the time, the content of Morgagni hernia is transverse colon. Am I right? Do you understand? Because on the anterior aspect is hernia of Morgagni. Just below the hernia of Morgagni, you have transverse colon, but that is why transverse colon will move up, and that is what is called as, and that is why you have a transverse colon as a content. This is a neat question. Bochdelic hernia, you see on the left side, just imagine what are the structures are there. You have small bowel, you can have stomach, you will have kidney, you will have adrenal gland. All these are the contents of Bochdelic hernia. Fine. See, Bochdelic hernia is most common. This is more common than Morgagnial hernia. To see the X-ray picture, bro, this X-ray is very, very important, bro. You can see one side of the lung is there, and the other side you can see the bowel loops here. These are not normal lungs, these are bowel loops, okay, which is present in the thoracic cavity, which means that this is congenital diaphragmatic hernia. Okay, so what will be the clinical features of diaphragmatic hernia? You will have pulmonary hypoplasia because the lung because the lung is being replaced by this bowel, so automatically this happened in the intrauterine life itself. That way the lung will not properly grow and you will have pulmonary hypoplasia. Clinical feature, respiratory distress. All the bowel loops are present in the thoracic cavity, so there is nothing, there will be nothing will be present in the abdominal cavity, so you can see a boat shaped abdomen. That is what is scaphoid abdomen. Okay, the abdomen will be very sunken in CDH. Coming to the management, you will, first thing what you need to know is to avoid BME. Never see, most of the time I told you about neonatal resuscitation also. When the baby is in distress, you can immediately go with bag and mask ventilation. Very important point. Here you should not give bag and mask ventilation. Then how will I know that a baby is born, the baby is with respiratory distress syndrome? How will I be knowing that this baby is having this distress is because of normal respiratory distress syndrome or because of congenital diaphragmatic hernia? Because if it is a normal respiratory distress syndrome, bag and mask ventilation is indicated. If it is congenital diaphragmatic hernia, bag and mask ventilation is contraindicated. See the abdomen. If the abdomen is scaphoid, suspect congenital diaphragmatic hernia. If you suspect congenital diaphragmatic hernia, take an X-ray. Just it will be present inside the theatre itself or somewhere outside near. Go take an X-ray. See, when you see a picture like this, throw your bag and mask ventilation. Okay, throw that instrument. Don't do. I will tell you what will happen if you do, bro. When you are doing bag and mask ventilation, some amount of air will also go through the esophagus to the stomach, to the gut. 80% of air goes into the trachea, and at least 20% of air will go to the esophagus also, no? Because we are just pushing air. We are creating a positive pressure. So when it goes to the esophagus, it will go to the gut. When it goes to the intestine, it will go to the thoracic cavity. When it goes to the thoracic cavity through the gut, the gut will expand. When the gut expands, it further compromises the lungs. That is why bag and mask ventilation is contraindicated. Be logical. Fine. But what you can do is we can intubate the patient. Bro, in intubation also we are giving positive pressure only. Bro, intubation is only in the trachea, bro. We are not giving it in the esophagus, bro. That is why intubation is indicated. This is repeatedly asked in Neet question. What is the management? Initial management is to intubate the baby. And the intubation level, we will have to set up a high frequency rate. Respiratory rate has to be on the higher side. Fine. You can, if the baby is not even settled with intubation, you can go with extracorporeal membrane oxygenation also. Okay. Only after 48 hours, you will have to go with surgical treatment. Once again, the problem here comes with the next and best management. See what the examiner is asking you. Okay. See what the examiner asks. If the next step is asked, then it is intubation. If the best management is asked, then it is surgical management. Only after 48 hours, only after stabilizing the baby, we will be doing this surgical treatment. Surgical treatment will just reduce the hernia into the abdomen, and will be, if the defect is small, we can go with primary suture. If the defect is very large, then we will have to put in some polythene mesh, exactly like hernia surgery. We put in a mesh to cover the defect and be suturing it. Actually, prognosis depends on pulmonary hypertension. I told you congenital diaphragmatic hernia happens in the intrauterine life itself. It is not after delivery. It happens in the intrauterine life itself, because of which the lung is not properly developed. If the lung is not properly developed, automatically you can expect pulmonary hypertension. If the baby is having pulmonary hypertension, it is a poor prognosis. Early onset respiratory distress is also a poor prognostic sign. Fine. Okay. I think I'm over with the topic. That's all about today. Thanks for watching.